Hello, everyone online, and please join us with the next section. And the seminar organizing committee next invite Dr. Masae Kawamura to talk about the QuantiFERON T Gold Plus, a new benchmark in TB testing. And Dr. Masae Kawamura, she is a very experienced TB clinician, and she was trained in internal medicine, Kaiser Performance Medical Center in Santa Clara, California, and she has been working with TB and has been working on the TB diagnostic and treatment, and please join us, please, Doctor.
Thank you very much. Happy to be here. Thank you, Dr. Liu.
Yeah.
Be presenting this presentation on QuantiFERON TB Gold Plus to you. And I want to congratulate Taiwan for getting this product registered because it's very exciting. And I hope that this presentation expresses that. First of all, my disclaimer, this presentation is not a QIAGEN presentation. I am employed by QIAGEN, however, but these slides are my own, and it's really based on my experience as a TB clinician and former TB control director. QuantiFERON TB, where we are today in the world, is that it is the new standard. It is an FDA-approved IGRA that's also recommended and endorsed by the WHO, equal to the skin test. QuantiFERON is replacing the skin test in the best TB programs in the world. And I consider Taiwan's TB program one of the best in the world as well, probably the best for COVID control as well. But, you know, they use QuantiFERON like we do in the United States. QuantiFERON also performs consistently in all the risk populations that we would want to test for TB. And it is the global research standard for all TB vaccine trials, for pharmaceutical research, including the biologics. It is the test that is used for national LTBI prevalence surveys and for diabetes latent TB infection research as well. So where we are is we have had QuantiFERON now for almost 20 years, and we are on the 4th generation. And the 1st generation was first FDA approved in 2001. And I never thought I would ever see the day when the skin test became a blood test, but it did. And that 1st generation actually used PPD, so it wasn't as specific. Until the next generation came in 2004, FDA approved, and these antigens were revolutionary. This was really the game changer for IGRA testing, where it changed the PPD to BSAT6 and CFP10 that has 99% specificity for tuberculosis. And so for BCG vaccinated populations, this really reduced the false positives. But it really wasn't until the 3rd generation where we had FDA approval in 2007, it turned the liquid ELISA test into a in-tube version. Antigens were put into the tubes, and so this really allowed us the incubation step to be separated from the ELISA test. And then suddenly that you had 2 to 3 days to run the test. It was much more flexible in terms of pre-analytical workflow, and the large commercial labs were now able to run this test, and as a result, scaled up worldwide in every region of the world, over 60 million tests sold, and an explosion of peer-reviewed publications. So now we're on the 4th generation test. It was CE marked in 2014 and FDA approved in 2017. So it's actually been out there, and Taiwan will see the benefits because there are more publications on it. But it is, again, a new benchmark because it has new antigens that are patented and are CD8 directed, CD8 T cell directed. And it is a potential biomarker for intracellular TB burden, the first of its kind. And there are other flexible blood draw options that I'm going to talk about. There are also operational evolutions besides the addition of the new antigens. And you now are able to draw the blood into a single lithium heparin tube. And there is a full automation that will not only transfer the blood, but will shake the tubes. And then you also have, in addition to ELISA automation that has been out there for quite some time, a new detection platform via chemiluminescence. And the DiaSorin platform, the Liaison, is a newly FDA-approved workflow. And so you have that option as well to get your results. Before I get into QuantiFERON Plus, I just wanted to show you the key publications that we have for QuantiFERON Gold into. And I like to say that QuantiFERON Plus was really built on the shoulders of our previous assay, which by the end of its life had very strong publications in key journals showing its important utility in testing high-risk groups. So what is QuantiFERON Gold Plus? What's the plus in plus? It's actually you test it's the same test principle as QuantiFERON Gold Into, except there are new workflow options and potential insights from the CD8 antigens. The performance, in our registration trials in active TB culture-proven disease was 94%. The specificity is 97% or better. Like I mentioned, there's the CD8 T cell technology. There's been improvements in the test formulation and manufacturing. The way the antigens are sprayed in the tubes it's different. But this is the exciting part, is the ability to now draw the blood into a single lithium heparin tube, which you would later transfer into the QuantiFERON tubes. And if you refrigerate the lithium heparin tube as soon as it's drawn, you have actually up to 2 days or 53 hours to transfer that blood to the QuantiFERON tubes and add more time if you're drawing from a remote site. So this is really an advance. And also for hot countries, it will stabilize the blood transfer, the temperature, and you wouldn't have to worry about samples getting too hot. Furthermore, the single tube draw is valuable from the standpoint of large contact investigations. It's much easier to draw 1 tube instead of 4 tubes. It's a faster draw because the QuantiFERON tubes have only 1 ml volume, which means the vacuum is much slower. And you can treat the samples like any routine phlebotomy. It doesn't require any special training to draw the samples into the QuantiFERON tubes and the shaking, which is a very important part. From a laboratory and academic perspective, that pre-analytical process is now under the full control of the laboratory, and the QuantiFERON tubes will be in the laboratory, stored there, and managed in-house. There's no more need for tracking of tubes going out to different sites, worried about expired tubes, et cetera, et cetera. And I think the biggest point of the single tube is the potential to minimize the indeterminate rates, which of course have to be the patients will have to repeat testing if they have an indeterminate oftentimes. Also from the patient perspective, drawing 1 tube is less blood than 4 tubes, even though actually it's not true, right? You're drawing less blood in the 4 tubes, only 1 ml, whereas in a single lithium heparin tube, you'll be drawing at least 5 mLs. But it is a faster blood draw. This will be is quite important for pediatric populations. So what did I mean when I said the single tube can actually lower the indeterminate rates? Well, we know just anecdotally from our own study, the center study in the middle, from our registration trials, that when you draw into a single tube and transfer the blood later, you get almost perfect results and no indeterminates in our case out of 733 patients. The SEQUEL study found only one patient with an indeterminate out of 263 patients for an indeterminate rate of 0.4%. But I want to point out the last study here by Gallagher. They actually used QuantiFERON Gold Intube and did a study in 2015. They were very unhappy with a 4% indeterminate rate that they were getting from their migrant clinics. And so they did a study in 4,615 patients, multiple sites, and were able to reduce their indeterminate rate to less than 1%, 0.2%. So the elimination of that external pre-analytical process can minimize the indeterminate rate. So let's talk about the CD8 T cell technology. Why did we add CD8 antigens? It's because CD8 T cells play a very important role in fighting TB in the body. CD8 T cells are specialized killer cells once they are adapted specifically to target the pathogen. And unlike CD4 cells, they kill the cells that are infected. CD4 T cells are more like the generals of the immune system and direct other immune cells as to what to do, basically. Whereas CD8 T cells are like the CIA, the M16, and they will find their target and go after them. They can suppress TB growth by interacting with an infected cell. They can actually program that infected cell to die or program that cell to lyse the intracellular TB. So it is known as a biomarker for intracellular load, bacterial load. And where do you see the CD8 T cell response? Well, you're more likely to see it in active TB versus latent TB. These are studies that were done prior to the development of QuantiFERON Plus. It's also associated with recent exposure to TB or new infection before the bacteria is controlled in the body. We also know that the CD8 T cell response is very good in HIV co-infection and in young children, which was really important for the development of this assay because CD4 T cells drastically impacted all IGRAs and the skin test. So we're looking for a solution to boosting the sensitivity in these populations. And also you see a decline in the CD8 response in patients that are being treated for active TB. Again, correlating with that intracellular burden, right? As it declines with treatment, you should see a decline in the CD8 response. And what we also know about TB infection now is not that it's just latent or active. There's actually a spectrum of infection. Your innate immunity can actually eliminate the organism and you never get the adaptive response. But once you get the adaptive response, your skin test or your IGRA test will be positive and until perhaps you reduce the immune, you get immunosuppressed by active disease. What you would expect with a CD8, if you look at the bottom of the screen, is you would see an initial burst of response and activity by CD8 with the adaptive immune response. Once the bacillary burden is controlled, you would see it go away. And if the latent TB is turning into subclinical TB disease, you would see an increase in your CD8 signal with a maximum signal seen in active TB disease. So the QuantiFERON Gold Plus format has 4 tubes. There's a negative control, the nil control, and mitogen control or positive control, which is the same as in the prior assay. But we have added another tube, and so there are 2 tubes, antigen tubes. The green top tube is the TB1 antigen tube. The yellow is the TB2 antigen tube. TB1 contains long peptides, ESAT6 and CFP10, that stimulate CD4 T cells. And the TB2, the yellow cap tube, contains additional short proprietary peptides that stimulate the CD8 T cells. Some of you may notice that TB7.7, an antigen that was in our previous version, is no longer in this assay. And that is because in the pre-registration trials, it did not show, it did not add any sensitivity to the assay and just cost, and so it was removed. So people ask, why 4 tubes? Why didn't you just keep the TB2, the yellow cap tube, and go with that? And the reason for keeping this format was that you actually have more data now in a single test. You have 2 data points instead of 1. It's like 2 tests in 1, really. And secondly, it allows you to calculate the CD8 response. Since TB2 has both CD4 and CD8, if you subtract the value of TB1 from TB2, you will actually get the CD8 response, which I'll show you hopefully will have some value to you. So this data comes from our package insert. When you categorize patients into low, mixed, and active TB, what you see in the low risk group is you really don't see CD8 response. You shouldn't really, right? They're not newly infected, etc. But when you have a mixed risk group where you have contacts and homeless individuals, etc., you will see a few of them that have a CD8 signal. But when you compare that to active TB, you can see that in this cohort, the majority have a CD8 signal, and that signal is much stronger. So what does it mean? Well, in LTBI, you wonder whether these patients that have a CD8 signal have recent infection and whether they are more likely to progress. This is a really important topic for TB control because they are the ones who have the highest rate of progression, those who are newly infected. And that's why we focus on contacts so much. But in the suspects, you know, if you have a strong CD8 signal and you're not sure about the clinical presentation, perhaps this could help you move you towards a diagnosis of active TB. But I'd like to warn the audience that if you do not have a CD8 signal, that does not rule out active TB or subclinical TB or even latent TB infection in a setting of a contact, right? So because you still have a lot of individuals who are negative for CD8 response with active TB, and we actually don't know why that is. However, if you have a strong CD8 response, and you definitely have a CD8 response, then perhaps you can use that and in the context of your patient scenario to manage your patient. So the independent studies now are really growing, and there's enough studies to even do a systematic review. This is a new study. There are actually 2 systematic reviews with almost exactly the same results. I'm showing you the first one. And basically it was done in a classic style of removing bias, etc., describing 15 articles that were analyzed. And basically what they found was that the studies from 8 different countries, the sensitivity in active TB was 94%, which is exactly the same as our package insert, with a pooled specificity for healthy individuals of 96%. They also calculated sensitivity and specificity for LTBI based on comparing results to, I believe, QuantiFERON Gold Intube, and found a 91% sensitivity and 95% specificity. I think this is not accurate, actually, because you can only determine specificity in individuals that are not infected or have no risk for TB infection. But their conclusion was that the TB2 peptides increase the sensitivity of QuantiFERON Plus of the assay without affecting the specificity. And that overall it was more sensitive. So this was really a really happy finding for QIAGEN because the whole point of this assay was to improve its performance. And the CD8 studies are really interesting. And even before, we had a lot of articles on CD8 T cell responses in context. The 2016 WHO TB report included QuantiFERON TB Plus in their report, citing a study that indicated that the CD8 T cell response may be able to identify individuals who are at greater risk of progression, and meaning those who are newly infected. And that first study is on the top here by Bartolini. And I'm just summarizing because now there are actually 4 studies and growing in this area. These are studies in contacts, and you can see the numbers there. They're adding up. But look at the positive rates by QuantiFERON Plus, very high positive rates, over 42% in this high-risk population, as you should see in contacts to active TB. But the percent of individuals who were positive that have a CD8 response is also high, ranging from 13.3% in Taiwan to 33% in the Netherlands and Belgium. So you can see a range here. And what's interesting is that in Mongolia, the CD8 response was also associated with vitamin D levels. And when we're talking about a CD8 signal, we're talking about a large signal, not a small one. And so they use a cut point of over 0.6 international units per ml. Now, this is not a validated one, but it is one standard deviation away from the cut point, and hence in studies, investigators are using it. So Taiwan University also did a very interesting study looking at a variety of patients, 336 patients. There were uninfected contacts, 118 of them, 105 contacts with latent TB infection, and 113 with active TB. These are mixed. Not all of them were culture proven. And basically what they found was that there was really excellent concordance between the third generation assay and QuantiFERON Plus. And they found better sensitivity in QuantiFERON Plus, although it was not statistically significant because the numbers are so small. And the sensitivity was 79% versus 74% for the third generation in 81 culture proven cases. Now, this is much lower than our package insert, but still, it's a small population, and these individuals may have been older and sicker. It's unclear why it's so different from the package insert. Nevertheless, QuantiFERON Plus did better. What they also found that is the first of these studies was that QuantiFERON plus positive third generation negative discordance was significantly associated with diabetes. So this is the first evidence that shows that QuantiFERON Plus may perform better in diabetic patients with active TB. And I think more importantly, the point of this study was really to evaluate the CD8 response. And what they found was a differential response that was higher and more frequent in active TB patients compared to LTBI, in culture confirmed versus the not culture confirmed or histologically confirmed, in smear positive rather than smear negative, in household contacts rather than contacts at a work site, and contacts living with the index case in the same room or sleeping in the same room versus not. So the CD8 response is really, in this study, correlated to burden, and they concluded that the differential CD8 response really was a clinical advance. So there are many published studies now. They're growing. I just wanted to show you that there are studies on impact of treatment, and there are meta-analysis, and the literature is growing, and it's still early days, I think, but so far so good. There really has not been a negative study to show that it performs worse than QuantiFERON goes into. But this is really the area, the immunocompromised patient, and comparisons to the ELISpot assay that we had hoped to make advance with this assay. And now we have greater than 60 published articles that include studies in HIV, the elderly, individuals on biologic agents, renal transplant patients, and then there's this first article showing some better performance in diabetes patients with active TB. So I'm going to go over one study in HIV and talk about the elderly, which I think is very important for Taiwan. The Telesinge study was the first study in HIV infected patients. It comes from Africa, and it was a small study of 108 patients, 80 of which were HIV negative, 85 were HIV positive. You can see that outlined in blue on the right of your screen here. And you can see that the sensitivity in these were not culture proven, smear positive or expert positive diagnosis of active TB. You can see that the sensitivity of QuantiFERON Plus was higher than the HIV in the HIV positives were higher than in the HIV negatives, 85% versus 80%. That's not statistically significant because of the small numbers, but when you compare it to a previous study that was done in 2007, outlined in gray there, you can see that with QuantiFERON Gold Into, the sensitivity was much lower in the HIV positives compared to the HIV negatives, only 63% versus 85% in the HIV negatives. What is more impressive, however, is the CD4 impact on the third generation QuantiFERON Gold Into. Under the CD4 count of 350, you see the sensitivity drop from 88%, 74, 70, and under a CD4 count of 100, it's dismal at 23%. When you look at QuantiFERON Plus, you don't see any drop in sensitivity until you reach a CD4 count of less than 100, which is still higher than QuantiFERON Gold Into. So what we learned from this study, and a study that I'm not showing you on LTBI, is that QuantiFERON Plus is not affected by HIV cells and is less affected by low CD4 count. The same is true in an LTBI study in pregnant women. In the three-way comparison study, looking at QuantiFERON Plus, QuantiFERON Gold, and T-spot in active TB, this study comes from Japan. It's a small study. You can see that the sensitivity of QuantiFERON Plus and QuantiFERON Gold Into actually was statistically significantly better than T-spot, with QuantiFERON Plus having the highest sensitivity and the lowest indeterminate rate. Two of the indeterminates from the QuantiFERON Gold Into were actually positive by the TB2 tube, and here you see the added value of that tube to not only maximize sensitivity in active TB. Now, this is a busy table, but I would like to point out something very important. The first column here are the patients under 80. They all the assays performed their best in that group. Over 80, however, you start to see QuantiFERON Plus pull ahead in sensitivity, 93% versus 89.5%. T-spot dropping off significantly to almost 72%. But in the far column on your right, Dr. Fukushima, who did this study, looked at the elderly with CD4 counts less than 200. And here you can see that it does impact all three assays, but clearly impacts QuantiFERON Plus the least, 82.6% versus 74% and 65% for the other two IGRAs. So, clearly QuantiFERON Plus had the best sensitivity, particularly in those with low CD4 counts. Again, mirroring the HIV story. This is very quickly a rheumatoid arthritis study in very ill patients, 154 patients, where over half of them were already on steroids, 53% on biologic agents, and 73% on methotrexate. So, you're supposed to test them before they're on these drugs. but here we are. Here, this study is on testing immunocompromised populations. QuantiFERON Plus was statistically significantly higher in positivity than T-spot, more than double, 9.7 versus 4.5%. And this is using the lowest cut point and fresh blood, which is the most sensitive method for T-spot. The indeterminate rates were also lower for QuantiFERON Plus, 1% versus 4%. But both of these results were lower than the background prevalence for this same age group of around 66.5, where the background is somewhere between 10.6 and 15%. So they concluded that both of these assays are not perfect, so you have to be careful about false negative results, but that QuantiFERON Plus, the positive rate was statistically higher than T-spot. I just want to, this is the last study I'm going to show you a brand new study. This is the only study in the world comparing the 4 assays, including the skin test. And basically, it showed excellent agreement in 506 patients that were tested with all 4 assays at once. Look at the 94% agreement between QuantiFERON Plus and QuantiFERON Gold Into. If they were discordant, the results, you found more positive QuantiFERON Plus than the other way around. And when they compared the agreement with QuantiFERON Plus to the skin test and T-spot, they found almost exactly the same agreement that you see with QuantiFERON Gold Into with the other 2 assays. So they concluded that the findings should reassure clinicians that the new QuantiFERON test, QuantiFERON Plus, is as good, is highly concordant with the previous version. To summarize, QuantiFERON Plus is a new benchmark with its CD8 antigens and moving the field of LTBI forward. We've got the 2 new meta-analysis showing better performance to QuantiFERON Gold Into. The CD8 responses are correlating to new infection in contacts, exposure, and TB burden in active TB. Also, when you compare it to QuantiFERON Gold Into, clearly QuantiFERON Plus is more sensitive in the elderly. And I didn't mention the work of Dr. Tien in Taiwan, but you will get a nice presentation from him, separate from mine. And unlike QuantiFERON Gold Into, QuantiFERON Plus is not impacted by HIV status so far anyway, and is definitely less impacted by CD4 count. And in the direct comparison studies in active TB, rheumatoid arthritis, renal transplant, it appears that QuantiFERON Plus is significantly more sensitive, or you see more positives than ELISpot against known background rates of latent TB infection. So I want to thank you very much for your attention, and I welcome your questions.
Masae Karamura, for your nice talk about the effectiveness of QuantiFERON TB Gold Plus, and it's very useful and with nice sensitivity and high specificity, especially in the low CD4 count HIV patient and the elderly. And so we have some questions from the audience, and the first one is that LI heparin as the collection tube was mentioned for several times in your speech. What is some important in using LI heparin tube? Can we use other collection tubes such as EDTA tube?
As far as the heparin tubes, you can actually, it's been validated for sodium heparin as well. So you can use the other types of heparin tubes as well.
But the EDTA tube, how about that?
I'm not the best technician, and EDTA, if it contains heparin, it probably is okay, but I would have to check on that or have our technical teams check on that one. Initially, it was FDA approved for lithium heparin tubes because it was the kind of heparin that was used in the registration trials. So you're not, allowed to say you can use any heparin tube, but I'm pretty sure that since that time, well, the sodium heparin tube has been validated, and I'm not sure about the EDTA. Hopefully, our technical team will be able to help you with that question.
Okay, we'll see that later. And the next one, false positive is always troublesome in using QFT because the treatment for latent TB is lengthy. The false positive rate has been reported around 3%. Is there any confirmatory test we can do for LTBF follow a positive result of QFT? What is the risk factor for a false positive result of QFT?
The risk factor for false positives is that you're not from Asia. You live in the United States, or you grew up in a place that did not have any TB. And I think it's very difficult to determine a false positive. People have repeated tests and they see changes in the results, especially if they're close to the cut point. But regardless of that, when they do repeat tests in individuals with, say, low interferon gamma values that are close to the cut point, those values can wobble, right? But what they represent is it is an immune response to the TB antigens. The hard part is that we're not God. We can't tell whether this is a true positive or just an aberrant below the cut point. And we don't also know whether those with lower values are at lower risk for progression. The third thing is we don't know where they are in their TB infection. So they may be at for example, they just recently got infected, so their value is lower and you're catching them on the lower side. And if you repeat it, it may be higher. So the risk of a false positive is really that you have someone who is not exposed to TB, absolutely not, and has doesn't come from that high risk population, and that the QuantiFERON value is lower. There are, if you have very high background rates of M. Kansassia and M. marinum and Sulgi, that could be another cause, but that is actually, within that specificity of 97%. But thank you for that question. It's a very good one. It's a very difficult question to answer in your population, Taiwan population. So I guess maybe one population where you would see more false positives is probably in your youngest population, in children under 5. If they've had no contact, they're still very young, and the risk of or the LTBI prevalence there is probably under 5%. You may see false positives there.
Since you have a very popular topic and we have more questions, but we are running short of time. So we may have Dr. Masae answer later, and we'll post to the audience. And thank you, Dr. Masae Karamura, for your nice talk. And we'll
sure. I'm happy to give the answers later. And thank you for the opportunity.
We'll move to the next session. Thanks.